What if I told you that the solution to one of the deadliest complications in global maternal health isn't some, billion-dollar drug,
Right.
and it isn't a fleet of robotic surgical tools either? Like,
Mm.
what if the difference between life and death for hundreds of thousands of mothers actually comes down to a five-letter acronym and a highly monitored bar of soap?
It sounds wild, but yeah.
Welcome to the deep dive. We know you are here because you want to get straight to those aha moments without, drowning in all that information overload. So we are just jumping right in. Today, we are looking at this incredible, just massive medical trial from our sources titled APT-Sepsis, Reducing Maternal Mortality Through Targeted Care Bundles.
And we should probably set the stage immediately here because this is not some theoretical exercise happening in a sterile, isolated lab.
Oh, definitely not.
Right. We are talking about a real-world, boots-on-the-ground mission to solve a truly heartbreaking crisis. The mission today for you listening is to understand how a specific, structured checklist of care drastically changed outcomes for pregnant women across entire countries.
Okay, let's unpack this. Because the core problem laid out in our source material is just devastatingly clear. Maternal infection and sepsis are, well, they are major causes of severe illness and death for pregnant women globally.
Yeah, massive.
And this crisis is heavily, disproportionately impacting low and middle income countries. But I think the most frustrating part of this source material is that this isn't some unsolved medical mystery.
No, not at all.
Right, like the deaths aren't happening because the medical community is stumped by the disease. They are happening because of the inconsistent implementation of evidence-based recommendations and delays in detection and treatment.
Yeah, that phrase, inconsistent implementation, that is the entire battleground here. I mean, the global medical community already possesses the evidence.
They know what to do.
Exactly. They know the exact antibiotics to use. They know the vital signs to monitor. But having that knowledge in a textbook and actually executing it on a crowded, under-resourced hospital ward at 2 in the morning, well, those are two completely different universes.
Yeah, when I was reading through this, an analogy immediately jumped to mind to try and, capture that disconnect. It's sort of like trying to bake a Michelin star souffle.
Okay, I like where this is going.
You have Gordon Ramsay's exact recipe right in your hands. You know the exact oven temperature. You know the exact whisking technique.
Wait, the science is there.
Exactly. But you consistently ruin the souffle anyway because your kitchen is just completely disorganized.
Yes.
The oven timer is broken. Someone borrowed your whisk and didn't put it back. And there are, 3 toddlers running around the kitchen with scissors.
That paints a very vivid and honestly a very accurate picture of the chaos.
Right, because it literally doesn't matter how good the recipe is at that point. The issue isn't a lack of culinary knowledge. The issue is that the chaotic environment completely prevents you from executing the steps.
Yeah, and that massive gap between knowing what to do and actually doing it in a high-stakes environment, that's the exact vulnerability the APT-Sepsis program was built to attack.
Oh, wow.
Because in resource-limited healthcare settings, you were dealing with understaffed wards, supply chain shortages, and just generally overwhelmed clinicians.
Overwhelmed is probably an understatement.
Truly. So if you just hand them a printed guideline and say, good luck, follow the rules, the environment is going to win, the chaos will overpower the good intentions every time.
So if the chaos of the environment always wins, how did these researchers successfully, organize the kitchen? How do you actually force consistency across dozens of busy clinics?
Well, you transition from passive guidelines to an active engineered system. The study employed this multi-component intervention called APT-Sepsis, which stands for Active Prevention and Treatment of Maternal Sepsis.
I want to break down the architecture of this because the source material outlines 3 very specific pillars they used to build this program.
Yeah, let's hear them.
First, adherence to World Health Organization, or WHO, hand hygiene standards. Second, the adoption of evidence-based practices for infection prevention and management. And third, the early detection of sepsis and the use of a specific treatment bundle called FAST-M.
Those 3 pillars, they represent a total overhaul of how a clinic operates day to day.
Now, I have to stop here and push back a little on behalf of anyone listening. When I first read that list, I honestly did a double take.
Why is that?
Wait, hand hygiene, that sounds so basic. Like, we are dedicating massive international medical trials to reminding trained doctors and nurses to wash their hands.
I know how it sounds, but
It just sounds almost insultingly basic. When we are talking about something as deadly as sepsis, shouldn't we be looking at futuristic, cutting-edge intravenous drugs rather than just soap and water?
What's fascinating here is that mastering the fundamentals is actually the most cutting-edge thing you can do when you are fighting systemic failure.
Really?
Yeah, to understand why, you have to really understand what sepsis actually is. It isn't just a bug you catch. Sepsis is a cascade.
A cascade.
Right. It is the body's own immune system overreacting to an infection, turning on itself, and literally damaging its own tissues and organs.
So the infection is just the spark, but sepsis is like the whole house burning down.
Beautifully put. And if you can prevent that initial spark, the infection, from ever taking hold in the reproductive tract during childbirth, you stop the entire deadly cascade before it even starts.
Okay, that makes sense.
But, to your point about hand washing being basic, in a high-resource hospital, sure, there's an automatic sensor sink in every single room.
Right.
But in many low- and middle-income clinics, the sink might be all the way down the hall. The soap dispenser might be empty. A nurse might be rushing between 10 different laboring mothers. So active management means you don't just tell them to wash their hands, you reorganize the ward. So hand sanitizing stations are physically right at the bedside. You create visual triggers. You assign hygiene champions. You engineer the environment so that doing the right thing literally becomes the easiest option.
Okay, I see the distinction now. You aren't just teaching the recipe, you are installing a better oven. You are aggressively blocking the spark, so you never have to fight the fire in the first place.
Exactly.
But let's look at reality for a second. No prevention system is flawless, right? An infection inevitably slips through the cracks. The patient starts running a fever, her heart rate spikes, the fire has started. What happens then?
Well, that brings us to the third pillar. Because when prevention fails, you need a rapid, aggressive response.
Yeah.
And the tactical tool they deployed for that is the FAST-TAM-M bundle.
The source details this acronym, FAST-TAM-M, and I really want to walk through it, but I need you to explain the clinical logic behind these letters. Like, why this specific sequence? Let's start with F. F is for fluids. If a mother is crashing from a massive infection, why is the very first step giving her IV fluids?
It's because of what sepsis does to the cardiovascular system. When that severe inflammatory response kicks in, blood vessels literally become leaky.
Leaky?
Yeah, fluid just shifts right out of the bloodstream, and as a result, the patient's blood pressure absolutely plummets.
No, wow, okay.
And if blood pressure drops too low, the major organs don't get oxygen and they just start to fail. So pumping in IV fluids immediately fills up those blood vessels, stabilizing the pressure and keeping the organs alive while you fight the underlying issue.
That makes total sense. You are basically keeping the engine running.
Right.
Which brings us to A. A is for antibiotics. I assume this is where you actually attack the bacteria.
Yes. In sepsis, there is this crucial concept called the golden hour.
The golden hour?
Yeah. For every hour that administration of intravenous antibiotics is delayed, the mortality rate increases significantly. You don't wait for lab cultures to come back 3 days later. You hit the infection with broad-spectrum antibiotics instantly.
Moving down the acronym then, S is for source control. What does that mean in a maternity setting?
Source control means finding the physical location of the infection and dealing with it.
Okay.
Like if there is retained placental tissue in the uterus causing the infection or maybe an abscess from a surgical wound, antibiotics alone won't penetrate that well enough. You have to physically remove the infected tissue or drain the abscess.
Wow. Okay, so F is fluids, A is antibiotics, S is source control, T is transfer if required.
Simply put, that's just acknowledging the limits of the facility.
Right.
If the patient is deteriorating and requires an intensive care unit and your clinic doesn't have one, the protocol forces the immediate logistical steps to transfer her to a higher level hospital. No second guessing. You just move.
And finally, M is for monitoring.
Continuous tracking of vital signs to see if the F, the A, and the S are actually working.
FASTM. What strikes me here isn't just the medical science, it's really the psychology of it.
How do you mean?
Well, think about the reality of a crashing patient. Alarms are ringing. Family members are terrified. The staff is exhausted. Using a memorizable 5-letter acronym just sort of strips away the panic of decision-making.
Exactly.
You don't have to try to recall some complex flowchart. You just think, FAST-TM. Have I done the F? Yes. Move to the A.
It entirely removes that cognitive overload. And remember, the core problem we discussed earlier, the delays in detection and treatment. This bundle is the literal antidote to those delays.
Yeah.
It standardizes the care so that a mother receives the exact same swift, comprehensive response at 3 in the afternoon as she does at 3 in the morning.
Here's where it gets really interesting because, a clever acronym is still just a theory until you test it.
Hmm.
You can't just try this on a handful of patients and declare victory.
Oh, absolutely not.
You have to prove it works under the crushing pressure of the real world. And the sheer scope of the trial they ran to prove this is staggering.
The logistics of this study are almost as impressive as the medical outcomes themselves.
They rolled this out across 59 health facilities located in Malawi and Uganda. And the total number of women who gave birth during this trial, 431,394.
It's massive.
I really want that number to sink in for you. Nearly 500,000 pregnant women were encompassed by this study.
And to figure out if the APT-Sepsis program actually worked across that massive population, they conducted what is called a cluster randomized trial.
Wait, before we move on, explain that term for us. What exactly is a cluster randomized trial? Does that mean they, flip a coin for every single pregnant woman who walks through the door to decide if she gets the special checklist or not?
No, and that is a great question. You can't randomize individual patients in a single hospital ward because doctors and nurses can't instantly unlearn a safety protocol between bed A and bed B.
Oh, right. That makes sense.
It would just be too messy. So instead, they randomized the clusters, meaning the actual hospitals and clinics themselves.
Ah, okay. So the facility itself is the test subject.
Exactly. They divided those 59 facilities into two groups. 30 of those clusters received the active APT sepsis intervention. Those are the ones where they aggressively reorganized the wards, trained the staff on the WHO hygiene standards, and drilled that FAST bundle.
Got it.
The other 29 clusters were assigned to the control group, which received what the study calls usual care.
Okay, let's talk about the usual care group, because I think people hear control group and assume these clinics were just, I don't know, abandoned or told to use leeches.
This raises an important question, right? What exactly constitutes usual care in modern global health?
Yeah, what does that look like?
The control group wasn't ignored. The source is very clear that usual care included the standard dissemination of medical guidelines. The ministries of health still handed out the rule books. The clinic still had access to the WHO recommendations on paper.
So this entire massive trial is essentially pitting two different philosophies of human behavior against each other.
That's a great way to put it.
It's testing whether actively managing the system, like the posters, the champions, the fast M drills, is actually better than just giving highly trained professionals the printed recipe and trusting them to figure it out.
That is the ultimate test here. Does organization beat education alone?
Let's get to the results then. Because when you pit those two philosophies against each other across nearly 500,000 births, the data is absolutely stunning.
It really is.
The researchers were tracking a primary outcome event. In the intervention group, the facilities using the APT-Sepsis program, that primary outcome event occurred in 1.4% of the patients.
Okay.
In the usual care group, it occurred in 1.9% of the patients.
Now, a 0.5% difference might sound tiny if you're just glancing at a spreadsheet, but across hundreds of thousands of patients, that fraction represents a massive reduction in human suffering.
Yeah, the source notes that this translates to a risk ratio of 8.68. Now, I am definitely not a medical statistician, so let's translate that into plain English.
Please do.
Instead of getting bogged down in risk ratios, let's make this real. It means that for every 100 women who would have suffered this primary outcome under standard usual care, the APT-Sepsis program saved 32 of them, a 32% reduction in relative risk.
It is a phenomenal achievement. But to really grasp the weight of that 32% reduction, we need to look at what that primary outcome actually measures.
Right. What is the event?
It is a composite metric of three very grim realities.
Yeah.
Infection-related maternal deaths, infection-related near-miss events, and severe infection-related illnesses.
And the source specifically defines those severe illnesses as deep surgical site, deep perineal, or body cavity infections. I mean, just hearing the phrase deep body cavity infection is so visceral, that sounds agonizing.
It is horrific. And I really want to draw focus to the phrase near-miss events. The source defines these as events in which women survives a life-threatening complication. A near-miss means the mother didn't die, but she went right to the brink of organ failure or septic shock.
She survived, but at what cost?
Exactly. Reducing those near misses and deep tissue infections by nearly a third spares countless families from the immediate trauma of almost losing a mother.
Yeah, the emotional toll alone.
But beyond the immediate terror, it spares them from the long-term, debilitating fallout. Surviving a life-threatening complication in a low-resource setting often means extended hospital stays, prolonged recovery where the mother literally cannot work or care for her other children,
Wow.
and healthcare costs that can plunge a family into generational poverty. By engineering the system to avoid the complication entirely, the APT-Sepsis program isn't just saving a life, it is preserving the economic and emotional foundation of entire families.
That reframes the whole thing for me. The stakes aren't just a clinical outcome, it's the ripple effect on the entire community. And what gives these results so much indisputable weight is that this wasn't a fluke. It wasn't one highly funded flagship hospital skewing the math. The source confirms that this 32% reduction was consistent across the board.
Yes, everywhere they tested it.
It worked in Malawi, and it worked in Uganda. It worked in massive urban hospitals, and it worked in smaller rural clinics. And I think most importantly, it was sustained over time.
If we connect this to the bigger picture, this trial fundamentally proves that medical science alone is insufficient. We have spent decades hyper-focused on discovering new drugs and writing better guidelines.
But just writing guidelines isn't enough.
Disseminating guidelines is not an intervention. This study proves that structured, multi-component, actively managed systems are vastly superior to standard care. The system itself is the medicine.
So what does this all mean? Let's bring this all together for you. Beating maternal sepsis and perhaps beating many of our greatest health challenges isn't just about understanding the underlying biology of a disease. It's about engineering human behavior. It's about acknowledging that doctors and nurses are human beings operating in chaotic, highly stressful environments, and they need more than just a rule book.
They need help.
They need a system designed for success. They need the ward organized so hand washing is frictionless. They need evidence-based practices baked right into their daily routine. And they need brilliantly simple, rapid response tools like Fast Tem to cut through the panic when alarms start ringing.
Yeah,
You have to organize the kitchen so the recipe can actually be cooked perfectly every single time.
I think the most profound takeaway here goes far beyond maternal health. This study proved that taking existing, decidedly unglamorous knowledge, things as simple as hand washing and basic broad-spectrum antibiotics, and packaging it into a highly structured, aggressively monitored system saved an immense number of lives.
Yeah.
It makes you wonder, what other massive global crises are we currently failing to solve? Not because we lack the scientific cure or the magical breakthrough, but simply because we haven't figured out how to consistently implement the recipe.
Wow, that is exactly the kind of question we want to leave you with today. The cure is truly only as good as the system delivering it. Thank you so much for joining us on this deep dive. Keep questioning how the systems around you shape the outcomes you see, and we'll catch you next time.